Good morning, good afternoon, good evening, everybody. It is 7 o'clock in Washington, D.C., and with the time difference, it's afternoon and evening in many of your countries. Very glad you are all here to join us for this very important webinar on political economy. And I'm also very happy that Dr. Mohamed Pate is here to share his experiences related to this when it comes to health system reforms. Before we start, I'm going to ask to do a very quick round of introductions, and I would like to ask one person in each country office to quickly introduce who else is in the room so that we can very much move to the main content. I will first turn to Ethiopia. Marion, can you tell us who's there and who is maybe joining?
Sure. Yeah. Hi, Petra. So this is Marion, focal point. So for Ethiopia and DRC, I work at the GFF Secretariat. We have Agazit Teka with us here. She's working on health financing with the Ministry of Health. And there is Tsegane, who is just entering the room. And there might be some people as well from the Ministry of Health coming shortly, but they haven't arrived yet. Over to you.
Thank you, Marion. I know many ministries are very busy with the corona preparedness and so on. Pearl, in Ghana, we just heard you. Maybe you can tell us who you're expecting?
Okay, so my name is Pearl. We're expecting Dr. Emmanuel Odame from the Ministry of Health, and then Oti Ajikum from the World Bank, as well as Mr. Peter Yeboah, who is the chairman for the POP task force, as well as the executive secretary for the Christian Health Association of Ghana. Others indicated that they might be able to connect online, but I don't see them yet. Thank you.
Thank you, Pearl, and you're the liaison officer, right? Great.
Yes.
Then I'm moving to Pakistan. I know it's very late and that some people are possibly connecting remotely. Nosheen? Okay, thank you, Nosheen. I understand you're there, but you have a connection. So we'll come back.
You want me to introduce the Pakistan team?
Yes, please.
This is Alia. This is Alia Kashif, the senior health specialist, and I have Jazeb also connected, who's the health economist. And from GFF, we have Nosheen, but unfortunately, she's having some connection issues. So once Nosheen kind of figures that out, and we have also Supriya. So that's all of us. Thank you.
Thank you very much, Lima. I think Somalia was not able to join because we had problems with the room in Somalia, but I think Naoko, are you online?
Yes, Monique. Sorry, Petra. Good morning. This is Naoko. Thank you for connecting.
Thank you. Thank you for joining. And then I'm just checking Dushanbe. I know they were probably not able to join, but just checking. Okay, then I'm going to Tanzania. I already heard Dr. Misemo, and she told me that there would be some people connecting from Dodoma. Could we hear who's on the line?
Okay, we are connecting from there. It's Peter. Jiho and Mariam are also connecting through their offices. Like Dr. Misemo indicated, the government will be connecting separately in Dodoma.
Thank you, Peter, Chio, and Miriam for joining. Dodoma?
Hello?
Yes?
Yeah, this is Edwin Swai, WHO Country Office in Dodoma. So I'm just connected alone at the Dodoma office.
Thank you for joining us from WHO. Much appreciated.
Thank you.
I will come back to see if there are others who have joined from Dodoma. Zambia, Mary and colleagues? Okay. I saw Harare, so I'm moving to Chenjerai and Patron.
Greetings from Zimbabwe. My name is Patron Mafaone. I am the GFF Liaison Officer. With me is Mr. Chenjerai Sismai. He is the health specialist with the World Bank Office, and Dr. Anyashama Suka with WHO. Other colleagues may also be connecting remotely via WebEx.
Okay,
Thank you.
Anybody else from Zimbabwe? Okay, then we're moving to Chad.
Hello.
Good afternoon.
Hello, Petra. Chad is here. We invited about 30 people, but for the time being, we have the UN AIDS that's represented. There are 2 representatives of that organization. The WHO is represented by 2 people. Then there's the cultural and medical service of the French embassy that's represented, plus 2 people from civil society. But we feel that there should be other people arriving soon. And I must say that the World Bank is currently looking at its portfolio in Chad, and so the World Bank could not be represented here today. And I am the liaison officer for Chad. Thank you.
Thank you very much. It's good to see there's such large country platform attendance from Chad. I'm moving to Haiti. I'm sorry to hear. I noticed security has really not gotten much better, but I know Paul, I think you're connecting via WebEx. Is that right?
Yes, I'm here. Thank you. And there's also Dr. Grandpierre, who's our focal point, and he's going to be connected too.
Great. Welcome to you and to Dr. Grandpierre. Thank you for joining, as I know it's impossible to get to the office at this point in time. Madagascar, Hasina?
Hello, Petra. Hello, everyone. I'm Asina. I'm the liaison officer for Madagascar. We have some participants, but I think we'll get more people arriving soon because there are traffic jams in Madagascar, as always. I'm going to give the floor to the participants so that they can introduce themselves. I'm Yasu. I'm from the ministry. Hello. I'm Ellie. I'm also from USAID. I'm also from HP Plus USAID. Hello. I'm from the Ministry of Health, UCP. I'm from UNICEF. Hello. I'm from the Maristoff Association. I'm a doctor. I'm from the National Nutrition Office. So there you have it. Thank you.
Thanks, Agina. Great to see such a good delegation from Madagascar as always. Let me move to Mali. Mamadou?
Yes, we have here Dr. Yatara, who's the focal point of GFF in Mali, then the representative of WHO in Mali, Jean-Pierre Baptiste, and then Madame Fatou, Sila Abibatou, and then the UNFPA, and then somebody from the World Bank, Jean-Pierre Tatoué from the World Bank, Telly from the coordination unit for the Ministry of Health, and also somebody else from the Ministry of Health. We're waiting for the health advisor from the Netherlands, and we're waiting for representatives of civil society.
Thank you, Mamadou and Usman, for joining us, and all the colleagues there. Much appreciated. Mauritania.
No answer from Mauritania.
Thank you, Carol. Niger, Abubakar.
Hello, Petra. Hello, Mr. Director. I'm Boubacar. I'm the liaison officer for Niger. There's the focal point for the government, then who represents the Ministry of Public Health, and then one of our technical partners for health, and then we have also an organization of civil society represented, as well as WHO. We're waiting for other people because of a change in the daylight savings time issue. We're waiting for other people. We have the Ministry of Finance, Ministry of Population, and there's the Global Fund and Gavi, who were invited. So we're waiting for them. We expect them in a few minutes. Thank you very much.
Great. Thank you very, very much. We're very happy to see you all here. I'm not going to take any more time myself because I really would like to ask Dr. Pate to speak about political economy of reforms, his experiences, and if possible also for us to hear from you what some of the challenges are. I can hear I must have missed someone.
Yeah, Zambia is here.
Zambia. Great. Yeah. Mary, can you tell us who's there from Zambia?
Can you see us?
Yes, we can. Go ahead.
Okay, so I'm Mary, the GFF liaison officer. I think everyone will introduce themselves.
Rosemary Suk from the World Bank.
Dorothy Skazwe from Ministry of Health.
Sarai Malumo from WHO.
I'm Mangomani from Ministry of Health.
Moji Kalmazimba from Ministry of Health.
Chomba Wango from Ministry of Home Affairs.
Mwamba Walimchunga, Ministry of Home Affairs.
Maremos from CRHE.
Mwiche Angel from Ministry of Health.
Lee Chileshe from Ministry of National Development Planning.
Christopher Mazimba from Wish to Action Project.
Gabriel Sampa from SSHE.
Joy Walvita from Wish to Action and Options.
Yolanda Nofma from the Ministry of Health.
Binti Kabondo from the Ministry of Community Development.
I'm Sabevanko from Ministry of Health, Shadow Kunich.
Great. Thank you all for joining. Much appreciated.
Okay. There's one more.
Saxon Nobu from Ministry of Health.
Thank you. It's great to see such a good delegation. So I'm going to very quickly move to ask Dr. Pate to share his experiences and talk about political economy of reforms.
Thank you. And good afternoon, everyone. I think it's really great to see this turnout from all of you, despite what is going on regarding the COVID-19 outbreak. I think the outbreak itself reinforces the need for the kind of system-level work that GFF is doing, because at the end of the day, we need to strengthen national health systems to be able to preserve the improvements in outcomes, particularly for the most vulnerable populations in our countries. So I think it's very good that you're able to show up. Now, I'm no expert in political economy. I think GFF asked me to speak really from the point of view of a practitioner, of someone who had done a little bit in a country context a few years ago. And so I will share with you a few of my thoughts, my reflections with the benefit of hindsight several years after leaving office. I served in Nigeria for a 5-year period, first as CEO of the Primary Healthcare Agency and then as a cabinet minister in the federal government and member of the economic management team. Many of you who were in Dar es Salaam, I think I shared with you some of my stories, but there are several others that I know I will probably be hearing for the first time. So I'll outline a few of my reflections, and then we can have a conversation, and I hope we can be able to learn both ways from what I share, but also from your own perspective and your own journeys in your respective countries, knowing that not all that I say is relevant or may be applicable to your respective countries. So Nigeria has been quite a challenge for a very long time in terms of population health outcomes. And when I was opportune to be appointed by the president to lead the primary healthcare effort, it was evident that we had huge issues in terms of health outcomes. Health outcomes were poor. Immunization was very low. Polio was going all over. Maternal and child health outcomes, infant mortality, under 5 mortality, maternal mortality were all high. Contraceptive prevalence was low. And also fertility rate in Nigeria for almost 5 decades was very stable. Hasn't really changed when you look at the population structure over almost 5 decades. So how do you start? A very endowed country that spends quite a bit, more than most of our comparator countries. So when we look at that, where do you start? And we understood that, in fact, the inter-country differences, the differences in health outcomes between Nigeria and other countries was even less than what was within the country. The intra-country differences were quite significant. Between one part of the country to the other, huge life expectancy differences, almost twice infant mortality, several folds immunization rate. So there were issues of distribution of those health outcomes themselves. And then the socioeconomic impact between, let's say, the highest wealth quintiles and the lowest wealth quintile. There were almost 6-7-fold differences, which is very striking in Nigeria. So how do you start and where do you go? My understanding, and for the subject of this morning's conversation, political economy, is really about interaction of actors, institutions, policies, namely setting priorities and allocated resources and programs. So in that context, where you have a complex system, poor health outcomes, poor distribution, where do you start? And so I think upon lots of reflection, we understood sort of our own domain, which is leading a primary healthcare agency at that time, which is a federal agency, but relative to the Ministry of Health, relative to the Ministry of Finance, relative to the, in those days, the MDG fund, which the federal government had, the parliament, and also the subnational units, the governors, their own respective parliaments, the civil society, just looking at the institutional environment and situating our own agenda really within that context as well. Knowing that Nigeria had issues with performance in terms of its outcomes, in terms of even data and granularity of that available data, and so situated an agenda that was within that context, and also for Nigeria we knew it wasn't going to be able to meet the MDG targets, but how do we build momentum so that we can sustain it even post-MDG era? So we set first a very clear agenda, a very clear focus on maternal, newborn, and child health outcomes. And to deal with it, we took really 2 pillars. One was a focus on primary health care because overall health spending was not very efficient on the front lines and allocative efficiency within the health system, but also picked human resources as an entry point because that's the lifeblood of the health system. Any conversation we do on health systems that doesn't really look at how services will be delivered and the lifeblood of the health system, it will be abstract. So we took an effort to really deploy midwives, community health workers as a way of re-engaging with the frontline services, aligning federal, states, and local government in that direction so that we begin to improve services that will lead to improvements in outcomes. So that was what led to the midwifery scheme. But it took really an orchestration, the buy-in of the president to agree that the federal government will actually support the subnational units, will subsidize them, a deal that basically allowed the states to take federal staff, but also to commit to recruiting them over time, and a substantial allocation from the finance ministry and the MDG debt fund, debt relief grant, basically, that Nigeria had to invest in that midwifery scheme, because we thought that in a complex system, you can't change all parts of the system at once. You will touch all of them, but you have to focus on a particular area of priority and improve it so that over time, then the system begins to adjust from that. So focusing on the financing, on sort of additional resources and where it's allocated, but also the human resources to redistribute them. The reform there was the redistribution of health workforce because parts of the country had bad health outcomes. Maternal mortality was very high, but they didn't have the human resources. Other parts of the country had excess human resources, had similarly high maternal mortality, but not as bad as other areas. So it is really redistributing them to the primary health care centers, and I can talk more about that if needed. But really, that was the effort, and it was a complex interplay of different actors that led to us being able to do that with an evaluation component that showed, in fact, that it made an impact in terms of improving services in those areas. And we began to show results, both credibility, and then on the immunization front, really mobilized whole sets of actors, including civil society, to really begin to make progress, not only on polio, but also to use introduction of new vaccines as a way of strengthening the routine immunization system and to improve child health outcomes as well, because the two are also hand in hand. Now, 2.5 years after that, the president, after election, asked me to be a full-fledged politician and to be a minister on his cabinet. So I was fortunate enough to serve in the federal cabinet and also on the economic management team, which gave me a little bit more visibility in terms of the whole of government structural reforms, in terms of the resources of the country, how they are allocated across different priorities, and within that, the health sector bit. So as part of the economic management team, one of the first things we did was really push for a structural reform to take away subsidy that we were paying, which is about 25% of the federal budget, on hydrocarbon consumption. That's the fuel subsidy in 2011, 2012, early 2012. Basically to withdraw that because it was inequitable. Part of the issue, if you look at the distribution of health outcomes, is that a large chunk of our budget was channeled towards subsidizing fuel, which was not equitable. Most of the rural population didn't benefit from it. Those who benefited were the urban wealthy, those of us who had big cars that will drive and will take lots of hydrocarbon. And so that reform was a way to increase the fiscal space of government, and within that, to take a chunk of that money and invest in maternal child health outcomes, including a conditional cash transfer on the demand side. So that's sort of, by being in this whole of government conversation with the Ministry of Finance, with the President, with other ministers, we're able to really navigate the conversation such that the subsidy reform, which had nothing to do with the health sector directly, but to reuse it as a way of bringing in additional resources to finance basic health, to build on the momentum that we had started, really focus on outcome. Now there, how do you rally parliamentarians, politicians who are really looking for office with an argument that says, give us more money, but you'll not see the result that will help you get re-elected in 4 years' time? That's a huge challenge. And so we wove this narrative around saving 1 million lives. And to be frank, there was no logic or science to it. We just calculated the almost 700 or 800,000 children that were dying in Nigeria every year, and just extrapolated and said, okay, at least in 4 or 5 years, we can save 1 million lives if we can scale this and that intervention. But the idea was that by framing it around health outcomes, in a way, it wasn't a negative narrative that we're preventing death. We're actually saving lives. And that is capturing more the, the badness that would have happened if we had not intervened. So for us in health, when we immunize children through through primary health care, 99% of them perhaps will not get measles if they are immunized. But it's the 1% that get measles that really get the attention. But the 99% success doesn't really get accounted for, as opposed to other sectors, roads where you build stuff, or agriculture where you produce something. In health, is the death and disability and pain that we prevent, but we don't have a way of accounting that. So politically, weaving the narrative around saving 1 million lives was very powerful, because then it enabled the president to buy into it, the ministers in the economic team to buy into it, the parliamentarians also to buy into it. And we launched it, I think, in 2012. I think that was as part of the UN Commission on Life-Saving Commodities. And I remember John Barrazo, who is here, he was at USAID at that time. He was at the launch. I think he was at the launch of that. But that is 3 years precursor to the GFF, that commission. But essentially, use that global momentum, global agenda, translate it at the country level, build a narrative around outcomes, and rally people around it. And built it so that it was a multi-stakeholder coalition. Within the government, it was the federal government, the Ministry of Health, the agencies, the parliament, budget office. They were all really aligned around this narrative, but civil society, because they are very important advocates as well as the subnational level, the state governments, the local governments, because it will take a coalition to change the outcomes that we want to change, because it's not an easy task to improve, let's say, child mortality or reduce maternal mortality. No single entity can be able to do that. So politically, we had to create that narrative and build a coalition of set of institutions. But then that wasn't just enough to build a narrative politically. You have to match it with an investment case. So that was before GFF days, but we developed a very substantive investment case, which we socialized within government, including with the Minister of Finance. I asked the Minister to say, okay, we'll put $500 million of the subsidy money. We'll put also another 350 or $500 million from the World Bank and others, which didn't cover all the gaps. But with that, we invited the World Bank at that time, the Global Fund, Gavi, and others. I said, come and don't give us money first. Appraise our technical content of our proposal. Look at the institutional arrangements. Look at our fiduciary systems and tell us what you think. So they all came and looked at it, and they all didn't have really much more to add. And based on that, it was a lot easier for them to really come around and invest behind it. And then the implementation then was the challenge. Now, that program continued to be implemented for several years, in fact, after I had left government, after other ministers had come. But essentially, it changed the path of Nigeria from discussing primarily on the input side to really focusing on the outcomes that mattered. And that also came in tandem with series of wider governance reforms in the Nigerian health sector. The Health Act, which ultimately got passed, which then created a fund that is now going to reward health outcomes in a way and actions by subnational units in tandem with the federal government. So it's a very convoluted journey. It was not an easy or straightforward journey, but I think it has succeeded in changing the direction of health outcomes in Nigeria. If you look at the data from the DHS in 2013, 2018, and then the most recent DHS as well that had come back, 2008, 2013, and 2018 DHS data, and several mixed surveys. Not the same level in every part of the country, but at least it did it did make an impact. But it took a broad coalition. It took really an understanding of the interaction between different actors, the politicians and how they thought, the finance folks in terms of how they thought, and the technocrats who have particular agendas on immunization, on maternal and child health, and all of that to come together. So that's a bit of a summarized version of my long story. I hope you have, I mean, I don't know to what extent that is applicable in your context, but I will just stop here and maybe get your own reactions and your own lessons and questions, and then we can discuss more on that. Thank you. Yeah.
Thank you, Dr. Pate. That's very interesting and definitely a GFF journey. So very clear also why you are the GFF director. I'm going to ask all of you to take 2 or 3 minutes and send us a question or an experience you want to share from your country. Dr. Pate has another engagement in about half an hour, so we will need to, I want to give time to different countries, so I'm going to ask countries that have smaller groups to very quickly send the question, and then others to maybe who take maybe a little bit longer, because I want to get to the conversation. Questions you may have to Dr. Pate, something you want to share or something you want to raise about what you're facing. I know many of you, as you're developing your investment case, you're prioritizing your health system reforms. Where are you seeing challenges in the political economy? What are some of the issues that collectively we can maybe think about? I know Joy and others are pulling up the slide which shows where to send your question to. So for English-speaking country, please send it to me, Petra, and for French-speaking countries, please send it to Joy. So we'll take 2 or 3 minutes, and then we will come back to have the conversation. Thank you. Okay, so we got the first question coming in. So I'm going to ask Dr. Pate to elaborate on that, and then I'll start asking other questions as they come in. So the first question is, how did you, as a Minister of Health, manage to get other sectors to support the idea that the health sector would receive more resources? Easy question.
Easy question, yeah. No, thank you, but it's a very good question, and I will answer it with a bit of a story to give you a flavor of the challenge that we face in health. So when I was asked by the President to join the economic management team, which is primarily finance ministry, the energy sector, transportation, agriculture, planning, health had never been really part of the economic management team. It was seen as sort of really a service sector. You get your money and you just do what you need to do. And so there was a pushback. Why would the Ministry of Health be actually in the economic team? Why not other sectors like mining? So we had to justify why we should be in the economic team. And we flipped the argument and said that there is a value chain around health. There's an economic value chain, not only from the point of view of productivity in terms of improving health outcomes and nutrition, that improves the human capital, the quality of the human capital of the country and productivity in the long run. But there's also an economic argument, because then we use statistics from other places like the US, where health is the second largest part of the US GDP, where many countries is major employer, and it's an employing, it employs quite a number of people, and there's a whole value chain around it. And by that, we earned our sitting around this economic team, which discussed the whole of government sort of economic reforms. So that was one. But also really, I think we had a finance minister who we had a good relationship with, and we cultivated that very strongly. More than the relationship, what she said was that we had come to her with a sense of what she was getting for the investment in health. She said, otherwise, if you had just come and say, give me more money because I just need more money because women are dying, I probably would just give you a little bit of what you have always, just what you have received. But that we said, this is what we are going to do and this is how we're going to measure it. So that sense of focus and our priorities and the fact that we can be held accountable based on what we are going to be measured by helped her really get confidence that, yes, she can support us because she's investing in us and what we're doing for the economy. So we created that relationship. And then for the other members of the economic team, I remember the agriculture minister, we went to him and said, look, nutrition is an issue based on the data. There's a health part of it, and there's a much wider issue of rural development, water and sanitation, food, agriculture that comes into it as well. So can we have focal point from your end to work with focal point on our end on the nutrition agenda? So he saw himself part of the Saving 1 Million Lives because nutrition accounted for a large chunk of the under 5 mortality that Nigeria had. Similarly with education. So we made those connections in a sort of health in all kind of way that people can see how health interlinks with them. So with education, for instance, it was really around the human resources. They trained the pipeline, and in a way, we were all social sectors. Luckily, they had a lot more money in terms of the portion of the budget that they had, but it was an easy way. So that's on the executive side. Now, on the parliamentary side, that was a bit of an issue to shift mindsets to results, because for the politicians who are elected, they would like to see big hospitals and constructions and all of that. And so that was a bit tougher for them to start to see immunization, saving the lives of mothers as really a political win from their end as well. And so it really took customizing messages for those various stakeholders. You cannot just be in your corner and expect everybody will just seed resources because you are the health sector, but you have to frame it in the context of everyone's also interest, why they should be investing in health.
Great. Great, thank you. There have a lot more questions come in, so I'm going to ask you another question that is related to the private sector. Can you please share your insights in the role of the private sector in the Nigeria experience, and how did they participate in all of these health system changes that resulted in the outcomes?
So very early on, when I became minister, I wrote to the World Bank in those days. I wrote to the IFC and said, I want you to assess the landscape, the constraints of the private sector in Nigeria, because we know that almost half of the health services in Nigeria were provided by the private sector. And so, and government wasn't in a position where it can overnight provide all those services. So how do we, as the Ministry of Health, really engage in a constructive way? And the three outcomes from that assessment, that there were policy constraints. We had not really engaged with the private sector in a structured way, and that many of the private sector entities looked at the health sector policymakers and regulators almost with trepidation. It was a predatory regulatory environment whereby it was only how many, do you have radiographers, do you have license, have you paid your fees? That's sort of the kind of approach. So the people avoided interacting with the regulator because they felt each time they basically were being shafted by that. So, and there was also what we call a regulatory loophole because certain aspects of what the private sector needed was not, let's say, regulated by the health sector. The Ministry of Trade regulated aspects of it, the Food and Drug Administration regulated aspect of it, and the services quality were regulated by another entity entirely. And at that time, the health bill was still being in the making, so we didn't really have a regulatory framework that was good, that will enable the health sector the private sector to thrive. And then the access to capital was also a major issue, because that is the nature of the market, and the risks, and the financial market wasn't really developed enough. But one thing that we also realized was that the private sector itself was highly fragmented. There are lots of bed capacities. Much of it is corner mom-up shop. Really, the physician sets up a shop. He is the CEO. He's everything. And at the next door, another provider sets up. So they're very fragmented, and they didn't have much of strategic plans. They avoided reporting their incomes, because they didn't want to pay taxes. So as a consequence, they cannot access large amounts of capital because they don't have the track records to be able to show that. And so the consolidation was needed, but that's a longer-term agenda that needed certain vehicles in the financial markets. So what we did was we then created the Private Sector Health Alliance of Nigeria, which is PHN. If you look on the website, you'll find it. That brought public and private sector entities. So we got Aliko Dangote and a few other corporate leaders, banks, with us to co-found the Private Sector Health Alliance of Nigeria, with the aim of providing a platform for private sector broadly to play, but organizing the private health sector in terms of service delivery, in terms of innovation, including technological innovation, in terms of innovative financing, that was based out of Lagos, and that has continued up till today to run in the case of Nigeria. And then others came on, like the Healthcare Federation, as a way of really coordinating the private sector itself. Because if you have 10,000 private sector outlets, everyone in its own corner, it's difficult to, let's say, standardize, to even bring to bear even large amounts of resources for them. So those are some of the things that we did, and I think that has continued, because certainly there's a lot of potential for the private sector, but without good regulation, without good policy environment, what happens is that why would someone invest in improving the standards of the care they provide if someone can come in at a lower level and also get away with it? So the government had to regulate well, but not over-regulate, so that the private sector will see value in investing to upgrade their services, because they will get the returns, and at least certain segments of the market will be able to do that. Now, that is in the context of Nigeria. This is really relative to the worldview, our own policy context. I don't presuppose that this is universally applicable. In some countries, the private sector isn't really there. And that doesn't mean that they should now make private sector the dominant player. There are issues also in terms of the private sector. So this is not a sort of a universal policy prescription, but in our context, knowing the deficits that we had and knowing the mixed health system that we have and the entrepreneurial nature, we thought that there is a role for certain aspects of the private sector and that the $1 billion that we spend on medical tourism, for instance, could be retained at home if we have the private sector developed. Because $1 billion goes out of Nigeria to Dubai, to other countries, and goes to private facilities, even in the US, even in the UK. So we thought that let's, from a policy perspective, develop that part of our economy as well.
There are some very specific questions regarding some of the reforms. So Zimbabwe is wondering on the HRH distribution, how was that made feasible? Were there any incentives attached to the distribution that attracted health workers to move to areas where they were not willing to go before? And then Mali is asking, how did you expand traditional birth attendants? Because they have rural maternity wards where we would like them to join. And then similarly, Chad is wondering, how did this redistribution of health workers get organized, and how do you successfully build their capacity and train them?
So we mapped, based on the data that we had from DHS, where the highest maternal mortality was, the deficit, the primary healthcare centers, state by state, and then allocated initially 4 midwives. So we did a hub and spoke model, whereby 4 primary healthcare centers around a general hospital, a referral hospital, were selected, and we posted 4 midwives each to a facility so that they can have 24-hour coverage, including the off days that they would have. That is for the midwives initially. And they were subsidized by the federal government, but required the states to pay a counterpart, a smaller amount, and to agree with us in writing that they will recruit them after 2 years, because they were supposed to be state employees. So we're subsidizing them, we mobilize them, we give them stipend, we equip them, and then the local governments provided accommodation for them because they are not from the areas. So with that, the midwives started going to the underserved areas with the subsidy that we are providing at the federal government level. But they were also accompanied with training, with equipment, and we mix and match them, older midwives with younger midwives, so that there was coaching and mentoring also. We also got some retired but not tired midwives who were brought back, who were old enough to retire, but they were not tired. They still had some fire in them to really help coach the younger generation of midwives who were posted with them. So it wasn't only fresh midwives, but there was experienced midwives with younger midwives packaged in one group, and they had accommodation provided by the local governments. Now, over time, and the states took many of them, and they settled in those areas. So that's sort of the incentive package that we put in. Then in the subsequent wave, then we brought in community health workers. The reason why we started with the midwives was the community health workers were supposed to spend half of their time in the field as the linkage between a health facility and the communities. But because there were no midwives, many of them reverted back to the facilities and were not engaging with the communities, and they became the de facto health workers, and they were not very well trained. So once we had the midwives, it was easier then to put the community health workers to where we had midwives, and then expect them to be that interface with the communities, but they were also trained. So we changed their standards of practice, we gave them new guidelines, we trained them, and then enabled them with logistics in tandem with the local governments for them to be able to do what they needed to do. And then later we had the conditional cash transfer on the demand side. All this was evaluated. I think that we asked the bank at that time to do an independent impact evaluation. And within 9 months, they increased skilled birth attendance by 14% in the areas where we intervened. This was, I think, published in a book by the bank. So we built an evaluation to learn, and we learned that some of the incentives, the monetary incentives actually worked better than the non-monetary incentives. That's one of the takeaways from that. But it made an impact. So that's how we do that.
I have another question, which is, I think, a very important one. How do you see, this comes from Pakistan, how do you see the impact of the current economic challenges amidst the corona emergency and the tight fiscal space, specifically in the context of lower middle-income countries, in advocating for an investment case, and what possible issues one needs to address for building the political narrative for prioritizing the investments towards RMNCH and outcomes?
So I think the argument for investing in RMNCH outcomes, I think, has never been stronger. If populations look at sort of where they are and where they need to be in terms of their human capital over time, in terms of even their demographic transition and where they should be in the period ahead. I think the coronavirus sort of is really another reminder as to how health should be central to overall economic development. Because not only health in our respective corners of, I'm reproductive health, I'm child health, I'm nutrition. No, health systems and the public health function within the health system are interrelated. And that failure to do that exposes all of us, not only in health, but education, the wider economy, national security, all get affected by lack of investment in health. And so I think as we dig our way through the coronavirus outbreak, I think it should be easier for ministers of finance to see value in investing in strong primary healthcare systems, because then you will have the frontline workers to be able to pick diseases, to diagnose them, and when the crisis emerges, to contain them where you have the health workers present. If you don't have them, essentially they will move to your cities and they will pose a bigger threat. So I think the narrative is there. It's for us to sort of build on it, at least from the bank side. Many of you are aware the bank announced a $12 billion package. That is unprecedented. But the reason is that everyone recognizes that, look, this is a huge development challenge. It's not just about our corner of the pie. It's not just one sector speaking, but we're really speaking about the overall whole. Health should be at the center. There's health in all that needs to be sort of understood, whether it's education. Many schools, 20 countries are closing schools because of coronavirus. What does it mean for education in the long run? Even in the United States, universities are closing. So there is that aspect, and I think we should really use this. It's unfortunate, it's a tragedy, and certainly, but the narrative that should come out of it is that health is an integral part of wider economic development agenda.
There are some questions related to the financing.
Yes.
So Zimbabwe is asking, what can be the key elements for fragile countries that are heavily donor dependent to go about health system reforms? Tanzania is asking, what about the difficulties in engaging with the Ministry of Finance? What are the challenges for ministers of health to do this? And how do you ensure that the Ministry of Health first reaches out to the Ministry of Finance and not to development partners? And what can be the role of the GFF Secretariat to prepare advocacy packages or build capacity on acquiring negotiation skills? And also, you yourself, what plans do you have to support countries to engage other political leaders like ministers and members of parliament?
All right, that's a long, easy questions. But I think, this is a webinar, and I would say I speak from multiple perspectives because I've had the opportunity of, even for brief periods, sit at the bank, sit in government as CEO, but also sit as a minister, and then now back at the bank. I've seen the development of the landscape, and so I'll answer from that perspective, not necessarily sort of the bank's position per se. I would say that one thing that is unique about the GFF model is this country-focused, country ownership, and the starting point being the country budget. In the global development landscape, there's a lot of noise from multiple sources and lots of resources that get thrown at countries. But the starting point is your own resources, is what you have on the ground. And because no matter how, when I was in Nigeria, we used to tell people, no matter how much you like to save the life of a child in Borno State, for instance, you cannot want to do that more than the elected, appointed official in that state, for instance. And so the political leaders in the countries have the first, second, and third responsibility to invest in the health of their people. Everyone else should be there to support them, but they should set the priorities, set the agendas along, and use good evidence. And where folks can help them, let them step in and help them. Where folks have one or two reasons why they can't, then let them not do it. Because if you really go on the outside and sort of say you set the agendas, then you risk setting agendas that may not be relevant to your people, and you have a divergence in expectations, and you have lack of trust. But if you then start with your own domestic financing and say, how do you most efficiently use those resources, and where are those gaps, and how do others like GFF, Global Fund, Gavi, World Bank, because these other international financing institutions, they are not there perpetually. People come and go. And not only that, they don't have the full grasp of the pain points that you have as a country. They can misapply their resources if you let them just go. So you have a role to chaperone the direction and the priorities based on your needs and to execute on that. Otherwise, there will be a lot of dancing around, and the day they go, no progress will happen. I've seen that in the case of Nigeria for 10 years, there are lots of investments. But the investments were not commensurate with the outcomes that we are getting. There are countries that were, Ethiopia is on the, I looked at it, Ethiopia spent less than Nigeria and got better health outcomes. And there are lots of other resources that were coming, but they are not really much used. And the donors were busy. Everyone was busy. So my own thinking was that, yes, the donors are very important, but the agenda is a country agenda. And the priorities should be driven by the countries, informed by evidence. And where donors are not willing to really understand that, then maybe they're not helping you as much. Because if you go by the money, then you may not have a sustainable, let's say, support. You sort of go up and down, and you may not be making much progress. But then look within your system, what those opportunities, like our subsidy reform was an important milestone, because it was really outside the health sector, but we're able to expand and get $500 million that we invested in maternal and child health. That's domestic. And then we are able to set the pace. And people will ask me, I'm with the bank now, but the bank did not come on SOML until a year and a half after we had started it. We set the agenda, and then we got the bank to actually come in, and others came in because that was our agenda. It wasn't a World Bank agenda at that point. So my own plea will be countries, whether you are low income, low middle income, or wherever you are in the developed trajectory, to really start with what are the resources that you have, what are the package of services that are priority for you within the resources you have, what are those gaps, who is out there that can be able to support you, how do you implement them within the context of your institution, within the context of your political system, and in a sustainable manner to achieve the priorities for your people, so that you are on that path, and the partners that support you in that one are the partners that really are meant to help you make that progress. And the GFF in this context, and the model that it has, in my view, is one of those, it stands out. The other bit of it, and with much respect to using outside government systems, some donors might do that. But you have to be on the lookout, because sometimes those other channels might make it more difficult to build the institutional capacity of your own systems in the long run. And so while in the short term, they are going to be stopgap, in the humanitarian settings you might have other channels, but using your systems, I think, is where you should be able to pull countries. And here, I'm not speaking now, well, it's difficult to sort of distinguish that, but I think by experience, I would say that I'll not say this this comment. I mean, I think it's I've made my point, I think.
I think so too. I think you very much made your point. I'm going to go to the last question. There's one, well, actually, I'll put in one other in case you have a thought on it. Pakistan is asking, particularly given that Nigeria is also a federal state, which is something that they struggle with. What are the opportunities and challenges with that? And then the last question, which is the most important, if you were going back as a Minister of Health in Nigeria, what would you do differently compared with what you did?
Very good.
Yeah, no, thank you. I think that's an easy one. It's highly unlikely that I'll go back as a minister. I think I've done what I could, and now we've moved on. We'll try to make GFF work better and make the bank do more for countries and to achieve those outcomes. I think the Pakistan question. We benchmarked ourselves there are a few federal systems, and people tend to think of health systems as one, but Pakistan was one that we benchmarked ourselves. India, Mexico, and a few others, and even Ethiopia, I think, was also another federal system. I think in federal system, depending on how they are structured, ours, there was fiscal decentralization, but there was no accountability mechanism between the subnational units and the federal government. They could do whatever they had. All we had was soft power. And so we had to calibrate it and use it. And we had a national council that enabled us to set policy together with the states. But the soft power was helpful. That means money, human resources, the subsidies. But what I realized was data helped us tremendously. By making visible what was invisible, we got the attention of the states. When we broke down immunization coverage by states and started publishing them, I got a lot of pain from some of the governors because they were unhappy that their states were projected as being poorly performing. But it did something very important. It got their attention. And they abused me, but they responded and put the money where they needed to do. Some of them reacted to that. So using data as a tool to drive accountability was one thing that I thought was a way to engage subnational units. Because where you don't have the power to make them do what they don't want to do, it's either you give them incentive or you hold them accountable by exposing really how they are performing relative to important priorities. So in SOML, we had a scorecard, which was state-level scorecard. And with polio, we also had a scorecard. So every 3 months, I go into the president, we had all the governors, and I'll present the scorecard. And of course, those who are doing well will be happy, and those who are not doing well will be very upset with me. But they went back and did what we needed them to do. So it is a bit tricky compared to, let's say, where you have a unitary system, where whatever is agreed at the central government, it basically happens all the way down to the provinces and districts. In Nigeria, it wasn't that way, and it was complicated. So in agendas like introducing vaccines or even the midwifery scheme, it was important that we really got the ownership of the states and them to see that there is value that we're bringing to the table. I'm sorry I have to leave because of the COVID ongoings, but I want to thank you for listening, and I hope we can, at some point through the GFF, if there are other questions, I'll be happy to try to answer them via email if it will be helpful to you as well. But thank you very much. I have to run, I think.
Thank you, Dr. Pate. Thank you so much. I think I speak on all of the countries to thank you. That was very, very interesting. And I am sure also important for you all to hear a different perspective, different experiences. I hope we managed to answer most of the questions. There were so many interesting questions that I think there's one that I wanted to answer because I know the answer to it, that came from Niger. And so there was a question about what is the link of the Nigerian health development plan with the investment case. And what I wanted to highlight is that when Dr. Pate was speaking about his experience in Nigeria, this was before the GFF. So his experience of the political economy and the reform and how to go about the reform is very much in line with everything that we're trying to do as part of the GFF approach, as he was alluding to towards the end. So he developed an investment case for Nigeria to actually look at making sure the investments would be made that were needed. So he has told me before that's why he wanted to become director of the GFF, because he believes that this approach is very, very important, and he has lived it at country level. I'm hoping that as you may all still have a little bit more time, that you will actually take some time in your country team to reflect on some of the reforms you're thinking about prioritizing in your investment case and the political economy around that. And what does that mean, and how are you possibly, as a country platform, as a group of multi-sectoral stakeholders, multi-partner stakeholders, able to build a coalition? Because I think that this was the question from Madagascar as well, how to build a coalition with all stakeholders to increase resources for health and reduce out-of-pocket health expenditures. That's a question for you all to reflect on for yourself, because every context is also different, so every situation will be different. But if I look at like Zambia, you have so many people in the room that are all able to contribute to this, or in Chad, or in Zimbabwe, or any of you, where you are together. Why don't you take some time to reflect on what you heard? And what does this mean for you to move forward on this trajectory? Then aside from that, I'm going to ask if we can have the slide that shows what are the next upcoming sessions, so that all of you are aware what are the next ones. I'm going to ask Louise to talk about the upcoming webinar for this cohort, so that all of you can pencil in the future dates to be there. We will also, again, circulate it via email. We always send out an official invitation, but that sometimes takes a little longer to get to you. So I'm hoping that you can already take note of this sequence. Go ahead, Louise.
Thank you very much, Petra. Good afternoon, good evening to all of you. Good morning, if that's the case. Just very quickly before I go to the upcoming webinars, just a note to the liaison officers in the call. I've circulated a few days ago an invitation for us to have an individual meeting on the knowledge and learning strategy. So you can take it from there. We will also circulate at some point in the coming days the document to get your feedback. So feel free if you want to comment something with your country platform. That is also welcome, of course. Now, on the upcoming webinars, for this particular cohort, the next one will be on prioritization, and that's the 22nd of April for the entire country platform to join, or those that you believe are most suited to it. And there will be a preparatory meeting with the liaison officers on the 15th of April for that. So we'll meet the liaison officers on the 15th of April, and then we'll meet all together with the country platforms on the 22nd of April. Good. One last thing, if any of you in the call, liaison officers I'm talking to right now, if you weren't present in the last week's meeting, please give us a signal. We have a list of those. Lawrence is trying to put up a very simple short WebEx to catch up with you on that. Thank you.
So for all of you, the 22nd of April is the next one. I don't think which will be on prioritization for this group. And then the one after that will be on May 18 on monitoring results. Okay? So just for all of you to please take note so that we can welcome you at those sessions. We very much look forward to that. And I hope you found it useful. I certainly very much appreciated having all of you here and the very important, interesting questions that you asked, because they gave a lot more background information on what we can all contemplate on. So thank you very much. Have a good day. Bye-bye.
Bye. Thank you.
Thanks.
Bye, Petra.
Bye.
Bye, Petra.